Go ahead, Courtney. We're ready to start.
Wonderful. Thank you, Valerie. Good afternoon, everybody. And we'd like to welcome you here today for our 8th webinar in our COVID webinar series. It's been some time since we last met in September, and so much has changed in California. Today, we will be discussing supporting your units during COVID-19, co-hosted by CMQCC and CPQCC. I'm Courtney Bro, Associate Director of Quality at CPQCC. Thank you for joining us today virtually. This webinar is going to be quite informal, and we want to give you all a firsthand opportunity to interact and ask questions with some of our frontline perinatal leaders in Southern California. Next slide, please. Just as a few reminders, you are all automatically muted upon entry, and the chat function has been disabled. We ask that you utilize the Q&A box if you're having technical difficulties, and of course, to submit any questions you have for the presenters. We will be selecting a few number of questions that are relevant to our topic today during the Q&A portion, and the remainder of the questions may be used to inform the topics for future webinars in this series. And the slides and the webinar recording will be made available on our COVID resource website listed here shortly after the webinar. And due to rapidly changing guidelines around COVID-19, the slides and recording may be taken down after a few weeks. Next slide, please. And just as a disclaimer, the information that's shared in this webinar series and what is posted on our resource site are just examples of how hospitals, healthcare workers, and families in California are responding to COVID-19. We understand that each hospital is working with a different set of resources and constraints, and some of these recommendations presented may not apply to your hospital setting. So guidelines and recommendations should be adapted to fit your local needs. And as this is a rapidly evolving public health situation, we encourage you to consider the most recently available local health department and CDC guidance when developing your internal protocols. Next slide, please. I'm really pleased to introduce our panelists today. We have Dr. Main from CMQCC, Rosa Ortega-Tucker from Providence St. Mary Medical Center, Dr. Shrivastava, excuse me for that. Let me try that again. Dr. Shrivastava from Miller Children's and Women's Hospital Long Beach and UCI Irvine, Dr. Rao from UCLA Health, Dr. Martin from Loma Linda, and Dr. Cox from Miller Children's and Women's Hospital Long Beach and UC Irvine. Next slide, please. I'd like to recognize our physician leaders at our California Quality Collaboratives and co-leaders in these COVID webinar plannings. It's Dr. Elliot Main from CMQCC and Dr. Lee from CPQCC. And now I'd like to hand it over to Dr. Main, who will be giving us an overview of key data related to COVID in California. Dr. Main.
Thank you, Courtney, and welcome everyone, and special thanks to our panelists today. Next slide. We had a horrendous January, as this slide shows, in the US and in California. These are the cases in California. We thought we had it bad in July, but the late December, January peak dwarfed that by a threefold margin. What you see on the right is the race and ethnicity distribution of cases. As you can see in California, the Latinx population bore a disproportionate share of the brunt of COVID-19. The other races and ethnicities were either about the same or white and Asian were below expected based on their population. Next slide shows the deaths, not just the cases. And again, January was a horrendous month. And again, you can see that the Latinx or Hispanic populations was disproportionately affected, much more than any other race or ethnic group. Interestingly, in history, in the 19 epidemic, there were also two peaks. In March and through June, there was a peak, and then a much bigger peak in October through December. with deaths of up to 200,000 in a single month. Next slide. As always in California, we have to look at counties. And I've divided this into 3 slides. So Southern California, Central Valley, and the Bay Area to give relative comparisons. As you can see, in Southern California, everyone had a big peak in January, but that peak now has fallen pretty significantly, nearly in some of the counties back to where it was in the summer, in the July-August peak. This is the top line is the positive patients admitted to hospitals as opposed to just the cases that are positive in a surveillance screen. So this is actual patients admitted. The second line is patients admitted to an ICU bed. That has also fallen quite significantly. You can see San Bernardino County, which had a very big peak in July, and Loma Linda bore the brunt of that, now is down actually below where it was in July. The bottom row is the ICU availability, which is something that public health officials use to help discern the future of opening in terms of capacity. Next slide. Looking at the Central Valley, we see similar pattern. Again, some of the counties had much bigger peaks in July, early August, and others did not. But most of them now are at the peak in July. What's interesting, though, on reflection is we thought July and August were pretty bad. It is only in comparison to what we saw in January that we could say we're getting better. But look at the Central Valley available beds, and this is a concern. There are not nearly as many hospitals in the Central Valley, but you could see some of the counties only have 5 or 8 intensive care unit beds available. The last slide of the surveillance is the Bay Area. Next slide is, and you can see again, each of the counties had a big peak in January, February, much bigger than the July, though not all have gotten back down. Santa Clara County in particular, which is one of the first places in California to see the pandemic. It still is higher than what it was in July and August, so unlike some of the other counties we've seen around the state. So local data is very important, not only by state, but even in a state the size of California, knowing what's going on in your county ends up being important. At least in the Bay Area, our intensive care unit beds are starting to recover in their availability, which is important. So we saw in the very first slide, the number of deaths does lag the number of cases, and that has always been the case. It lags when they go up, and it lags when they go down. So hopefully we're going to start to see shortly a fall in the number of deaths in California. But I'd have to say this is an encouraging sign at this point. Going back to 1918, there were the 2 peaks I mentioned, one in the spring and one in the November, December, and then the great so-called 1918 or Spanish flu kind of disappeared. We can pray that that might happen here, but obviously we have to plan for the worst. So thank you, and we'll go on now to Christina Aldini.
Thank you, Elliot, for sharing the current state of the pandemic in California. I'm Christina Aldini. I'm Associate Director at CMQCC, and Courtney and I will be calling on our presenters today to cover topics and questions that were submitted by registrants during the registration process. Krista Sikowski, Clinical Lead at CMQCC, will be reviewing the Q&A that's coming in during the presentations today, and as time permits, we will go ahead and ask our presenters to cover as many of those as we can. So why don't we go ahead and get started? Everyone's on camera here. We appreciate everybody for joining us today. And Dr. Rao, we're going to go ahead and start with you. And it's really a question about testing related to the OB population. Dr. Rao, how do you manage patients that were previously positive? Do you retest? Is there a chance of reinfection?
Hi, so thank you for having me. I'm gonna just go ahead and dive right into that question. So the way we proceed with testing at UCLA is once you test positive, you are considered COVID infected until you are considered COVID recovered. We use a symptom-based approach regarding considering somebody recovered. In general, we use a 20-day marker, which is derived from the CDC guidelines, and it's especially considered conservative. It's for people who at least have severe disease. You can be considered recovered earlier at the 10-day mark, but that has to go through our infection prevention department. So in general, 20 days is what we use. It can be sooner, 10 days, but again, that has to be cleared with our infection prevention ID colleagues. Once you're considered recovered, we do not retest again for at least 90 days. There have been case reports of reinfection, although very few and far between, and therefore we proceed with no retesting, even though we do universal testing on admission, especially on labor and delivery. We do not retest if they are considered recovered, and that does last for 90 days.
Thanks, Dr.
Thank you,
Courtney.
Yes, thank you. All right, this question is for Dr. Shrivastava and Dr. Martin. Have you noticed a difference in how COVID affects women depending on their trimester of pregnancy?
Well, I think we aren't 100% sure yet. Hi, thank you so much for having me here today as well. We don't know all the details yet. We still have, I think, a lot to learn about the gestational ages and how that might affect it. But I do think from our anecdotal experience that we have seen some increased severity of disease in that late second trimester and early third trimester population. That seems to be accompanied with what we know about the physiology of pregnancy and the demands of oxygen consumption and need to support a growing fetus and how that might affect the respiratory status of a mother. It also seems that some women can be in any of those gestational ages and be just fine, but those that present with symptoms seem to progress more significantly if they're in that gestational age range.
Yeah, I'd like, thanks for having me as well. I'd like to echo what Dr. Martin said for the most part. I think our threshold for intervening is lower in patients in the second and third trimester, so we tend to follow them. And I would probably preface the whole conversation with the majority of the patients with COVID-19 tend to do okay. So it's the ones that end up being hospitalized are the ones that are obviously at a viable gestation and greater, and mainly because our threshold for intervening, if something happens or even giving oxygen in those patients is lower to begin with.
Right.
Fun.
Go ahead.
No, that was me. Thank you.
Sorry, Courtney. We're going to go over to the pediatric side. Dr. Cox, thanks for joining us today. Can you go ahead and describe your admission process for an infant of a COVID positive mom requiring NICU care?
Sure. So thank you so much for having me. I am going to describe what happens for a delivery that we attend and then for the baby that we admit to the NICU. So our entire team will attend the delivery. It is usually a physician, a fellow, and a resident, an RN, and an RT. We attend in full PPE, which is the hat, the mask, the glasses, gloves, gown, booties, everything. However, we have available space to resuscitate a lot of our babies in a separate room. So if space is available, we transfer the baby to a room next door or across the hall just to limit the exposure to the maternal COVID infection. We will resuscitate the baby and then transfer the baby to a giraffe isolette and close the top. Then the team doffs the dirty PPE, washes up, and then dons fresh PPE, and we walk the isolette to the NICU. We have been admitting the majority of our babies into isolation rooms. And in fact, when we were having a surge, we had a separate room that had different bays designated for our COVID patients. For the babies, We do not allow visitation for at least the first 48 hours while the baby is undergoing testing. But we have a NICU camera that is focused on the baby for the parents to be able to log in and see their newborn. We will test the baby at 24 hours of life with a rapid Abbott screen in the throat, and then again at 48 hours with a nasopharyngeal rapid RVP screen. And the baby will be cleared from COVID isolation if both of those screens are negative and the baby is asymptomatic. If the baby is positive on one of those screens, we generally use the 10-day cutoff point for clearance from isolation, plus or minus symptoms. We have not had any babies who have been symptomatic. So thus far, we've just used the 10-day cutoff for clearance for isolation.
Thank you, Dr. Cox. I'm going to move on, and this question is for Rosa. How have you managed perinatal staff members floating out of their cluster to other COVID floors? Oh, you've got to unmute, Rosa, sorry. Thank you.
So in the beginning, when COVID wasn't as ramped up as it got towards that peak, the nurses, the beginning of COVID, first of all, our census dropped dramatically. So we saw that patients weren't coming in as often. We have an OBED. Patients weren't coming in through the OBED as well. So it worked out that our census dropped, and we were putting nurses on flex. But then as we saw our numbers ramp up throughout the hospital, we were still on low census. We did meet with the staff and float them outside of their clusters. And when they did, they floated to the areas to work as aides, monitors, video monitors, not monitor techs. We had them be sitters. And at first we tried to keep them in the non-COVID rooms just in case they were recallable, that we could bring them back to the OB area. But then as the numbers kept climbing and climbing and climbing, we were getting to the point where we could not recall them. And they were being utilized for the same purposes as sitters, as monitors. And the staff, I have to say that I work with amazing staff. They saw the need. And though everyone had concerns because we're all trying to protect somebody at home, our children, our mothers, grandmothers, the staff really saw the need. And so, at that point we had all the PPE available, so that wasn't as scary as in the beginning where we might have not had all the PPE. But so the staff float in rotation. Towards the middle of our peak, then our staff were volunteering to float to the areas. Some of the staff really got a calling for going out there because it was so different than what they see in the OB areas, and just they felt their purpose out there, even though they were just working as aides and just couldn't get in there and do the hands-on patients. They needed nurses as well. Just their help was immensely welcomed on the other units. Again, being aides, helping turning patients. At the peak of our COVID rush, they were going into COVID rooms, again, helping turn patients, just doing CNA work and just, doing whatever they can to help our coworkers that were out of ratio and just, really, really tired and working day after day. We also saw a lot of nurses go out on leave, getting COVID and then coming back. So, the whole hospital took a hit, as did every hospital in California and probably in the country, with nurses being out. So, just the floating of our nurses out into the floors, as well as, surgical areas was closed, so we floated those nurses as well. We got nurses from the National Guard. We were just pulling the resources that every hospital needed. But as far as our nurses floating out, it just, it was hard in the beginning because it was uncomfortable for them, of course. But as more started floating and seeing what they were doing, then it just they were all helping each other and encouraging each other to help and just be out there for our fellow coworkers.
Thank you, Rosa. Vineet, I want to bring you in here now, a little bit about COVID treatments. What therapeutics have been used in pregnant COVID patients, and are monoclonal antibodies available to pregnant women at this time? And if so, how are they being used?
Yeah, sure. I think what it goes, when we see a patient with COVID, we immediately bifurcate the patients into those requiring oxygen and those aren't. Obviously, those that aren't requiring oxygen generally coming into triage for whatever the evaluation may be. If there's no reason for admission other than their COVID status, they would generally be managed by their private doctor and they even go home. Those patients that require oxygen generally stayed under the high risk service, so they would be under the management of the in-house perinatologist. If they're requiring oxygen, we generally had a standard kind of regimen in which we initially started them on dexamethasone daily, 10 days, 6 milligrams oral, and then obviously draw a standard panel laboratory, including transaminases, CBC, procalcitonin, D-dimer, etc. If their LFTs were within, I think, 5 standards of normal, we would also initiate them on remdesivir, most of which has been shown to either, in combination with the steroids, have reduced hospitalization or length of hospitalization and even improve mortality with dexamethasone specifically. And that would kind of be our initial regimen. We'd follow their procalcitonins and their white count. If the procalcitonin was elevated, we also initiated antibiotics, largely at the discretion of our in-house infectious disease specialist. Generally, they get started on a kind of a community-acquired pneumonia protocol, ceftriaxone and azithromycin. And that would be the kind of the standard approach and regimen to these patients. Obviously, the oxygen requirements would be dictated by, the oxygen delivery would be dictated by the requirements they had, but that would be the standard protocol. We also start them on albuterol and inhalers to kind of improve the respiratory function. And we would be followed along by respiratory therapy and pulmonology. As far as the question of monoclonal antibodies, we have started using them. The protocol, we're hopefully going to be started using them with infusions on labor and delivery itself. But until now, they're mostly administered within the emergency room. So if a patient was stable, with COVID positive but stable, non-oxygen requiring, we have a protocol in which we would administer whichever the medications available right now under the EUA. Right now in our hospital, it's bamlanivimab. Sorry, I'm butchering that. And we would have the patient admitted to the emergency room for their infusion if they met the criterion for the medication. At our institution, it's BMI greater than 35, diabetes, or pregnant, I think were the main criterion for our patients to be administered that medication. I think there are other monoclonal antibodies being looked at, specifically the Regeneron cocktail, although we have not used that yet, but we're at least in the works for trying to administer it on labor and delivery. And that's kind of the status of our standard approach to patients with COVID at this point is.
Thank you, Vineet. I'm going to turn this next question to Dr. Rao. It's around vaccination. And the specific question is, how are you counseling women regarding vaccination in pregnancy and while breastfeeding? Do you recommend patients wait to become pregnant after receiving the vaccine?
Yeah, that's a great question. I think I have this conversation multiple times in a day. So this is indeed an important topic to review. So essentially, what I like to tell patients is this will eventually be a risk-benefit decision that they'll have to make, because despite, SMFM and ACOG trying to really get as many pregnant patients included in the trials as they could. They just unfortunately were not included in any of the original trials or the safety trials that were done. And so therefore, I don't have official recommendations regarding safety. Now, with that being said, what we mentioned is that we do not, in accordance here at UCLA with SMFM and ACOG, we don't believe that any of this will be harmful for pregnancy. So this would be a theoretical risk to consider. And with that being said, it would be up to the patient to decide whether or not the risk of getting COVID is higher than their theoretical risk with this vaccine. There are a couple of reassuring things. One is that, many pregnant women have to date been vaccinated, many healthcare workers in accordance with ACIP guidelines, and many of them have registered on VSafe, which is part of the CDC's vaccination safety program. And therefore, we're, I think, close to 10,000 pregnant women now who have gotten the vaccine, and there have not been any safety signals yet from the CDC. The DART data, or the animal data from the trials, which have not been released yet, but preliminary results from the experts have not demonstrated any safety signals regarding the use of vaccine in pregnancy, whether it comes to animal reports. And there were a small handful of women who were vaccinated in both the Moderna and the Pfizer trials, without them at that time knowing about the pregnancy. And so that data hasn't been released yet either, but again, have not heard any safety signals with any of that stuff. And so at this point, it would just be a theoretical risk. And so it would, again, with very similar to what the SMFM and ACOG guidelines recommend is, we don't necessarily recommend or not recommend, but permissive language. So we strongly recommend that it's not withheld from pregnant women, so that it is available should they need it. With regards to breastfeeding, there's no data that it's harmful in breastfeeding. And I think there's a little bit more of a stronger recommendation to consider getting the vaccine while breastfeeding, because from a biologic standpoint, there should be no concerns regarding safety for breastfeeding and vaccinations. And regarding getting the vaccine and then getting pregnant thereafter, there's no time frame with which is considered safe or unsafe. That would, again, all just be a theoretical risk.
Thank you, Dr. Rao. We appreciate it. Okay, we're going to go ahead and go to Dr. Martin now. Courtney, how do you manage a patient that becomes symptomatic, such as fever, shortness of breath, after a prior negative test?
It's a great question. And just want to say also that I'm nodding my head over here because I'm in full agreement with all of the comments that Dr. Shrivastava and Dr. Rao have made, which I think is hopefully helpful to those on the webinar, knowing that I would have probably answered it identical to all of these wonderful physicians. And so I think we're all very united in that. Hopefully it's the same with this next answer, which is if you have a patient who's on the unit, possibly an antepartum, or was originally admitted and then developed something postpartum, while we certainly always consider the main things like chorioamnionitis causing fever, or some other more common result, endometritis, etc., absolutely we retest. One of the things that we still are trying to grasp more about the virus and what our testing capacities are is we want to know if someone's positive, but mostly we really just want to know if they're effective, right? But we don't really have a great way to delineate what that viral load is. And so when someone comes because of that, we know that at certain institutions, they might have one that's not as sensitive or is very sensitive. And so it may have missed them on admission, I guess is the real message there. And so, or they weren't at a high enough viral load that would have resulted in being infective at the time. And so we retest them with a PCR, hopefully, and then you can know whether or not they are positive at this time. But we've had a few patients, and we had a fair amount come through, who were negative on admission and then were positive later. And that resulted in fear, right, and stress among the staff. And so I just wanted to tie in as well, related to this topic, that if both people are masked, or if you are masked as a provider or a nurse at the bedside, and the partner is masked, we actually do keep our laboring moms or admitted patients masked until we have a PCR back. We do use an Abbott test as well to just initially screen them. And then if you have a mask, the chance of admission or transmission in that setting is maybe 6%. It does go up, of course, with prolonged time in the room. But what we often reminded our staff of was that if you're wearing your mask and you're taking your precautions, it's more likely you would catch COVID in the community without using masks and being at home or from other things. So we tried to really calm people in that way and also remind them that we're looking for infectivity, not just viral particle positivity, right? So they're two different things. So I would always retest. And then the other thing I was just going to add to the treatment and screening with that, we did a lot of chest x-rays, we did a lot of CRP level, which seems to be very sensitive to severity of illness, along with tracking some of the other lab values that Dr. Shrivastava mentioned. And I would also just remind everybody that although we want to be judicious about the testing and radiography in pregnant women, we also need to take care of them and educate our counterparts too, that if they're coming to the ER or they're coming other places and they have symptoms, that they really need a thorough workup to make sure that they are not progressing, and they need close follow-up afterwards. So I think, really making sure when they come in, if they're negative, to retest if you have anything that comes up again positive, and reassure your staff that wearing PPE is appropriate and they should be safe.
Thank you, Dr. Martin. We're going to go back to the NICU environment here. And Dr. Cox, this question is for you. There's two parts to it. The first is, what NICU visitation is recommended for a mother who tests positive for COVID? Is it an open bay environment? And then, have you had any COVID positive newborns in the NICU?
Sure. So we use a time and symptom-based strategy for isolation and visitation. So the way it breaks down is based on the mom's symptoms and need for oxygen. So if the mom was asymptomatic or had mild symptoms, we recommend a 10-day isolation with visitation allowed on day 11. If the mother had moderate or severe disease, which we define as needing oxygen or an ICU stay, we recommend a 20-day isolation with visitation on day 21. For the partner in care, we recommend a 14-day isolation and quarantine from their last contact with the positive mother. And for the second question, will you refresh what that one was?
Oh, sure. Have you had any COVID positive newborns?
Yes.
In the NICU?
Yes, we've had positive newborns in the nursery and the NICU. We've had 6 out of about, I want to say 80 positive mothers. We've had 5 full-term babies and 1 preterm baby, and none of the babies were symptomatic and none required extra care. None of the babies were readmitted within 30 days after discharge, and they all did very well.
That's great. Thank you.
Perfect. Thank you. Rosa and Kacey, we're going to kind of go to both sides here, both OB and newborn. Have you noted racial disparities in prenatal, postpartum, and NICU care due to the pandemic? If so, how can we approach these disparities from an equity lens? Rosa, do you want to get us started?
Sure. So on the OB side, as I said earlier, our census has dropped dramatically, and I really have not noted any disparities. The patients that would normally come in weren't coming in. Everybody that came in here, whether they were symptomatic or not symptomatic, the same standard was followed, but we really haven't seen the disparities during COVID because of, I think, the lack of patients coming in to get treated. Most of the patients that we've seen have been, close to delivering, so I think our productivity has probably never been better because patients are waiting to come in. Unless they've had issues, then they do come in, but even then they've waited to the last minute. So we have not really noted disparities during this COVID time.
Dr. Cox?
Sure. So I find this topic really interesting, and it's something I've been studying here in our local population. So just like how we know that there are long-standing systemic health inequities, we know that there is evidence that some racial and ethnic groups are being disproportionately affected by COVID-19. And we have seen that here in Long Beach and at our local hospital. So there are, inequities in poverty and access to healthcare, discrimination, education gaps, income gaps, housing conditions, and then all the various occupations. So what can we do? Well, while responsibly responding to COVID guidelines, which is school closures, work closures, social distancing, and masking, we need to realize that there are unintended negative impacts on our patients' well-being, their loss of social connections, and their loss of support. So we can encourage faith, family, cultural bonds. Those are good sources of support. There are community organizations, employee organizations, programs through different healthcare systems and the public health agencies. And we also need to encourage our policymakers and providers, other providers, to be a part in helping to promote fair and equal access to care. I would encourage everyone to look up the CDC, AAP, and ACOG resources. They have social media toolkits, they have print resources, PSAs, and some great videos that are available for free that everyone should take a look at. So we should all promote easy access to information for our patients, work on affordable testing, and equal access to medical and mental health care.
Perfect. Courtney, there was a question asked, and I want Dr. Shrivastava to go ahead and, Dr. Rao, to go ahead and bring this back up. We were wondering about, someone had asked about rates of PPH or neonatal sepsis. And Dr. Rao, you had said that those in ICU with critical COVID, yes, there are higher rates of postpartum hemorrhage.
Yeah, so to clarify, and I think, there's been some data regarding this as well, a large cohort study recently that was published that those who have more severe COVID tend to have more adverse pregnancy outcomes. And that's definitely what we're seeing at UCLA anyways. And we do have a good number of patients who are on ECMO, who are intubated in the ICU, who have needed to be delivered. And you can imagine when you're on ECMO and you need full anticoagulation, when you need to get delivered, you absolutely have to deal with the high rates of postpartum hemorrhage that come with delivery. A large portion of those patients who are in the ICU and critically ill and need to get delivered, they do end up getting delivered via C-section. And so that also will contribute to it. But yes, we have seen higher rates of bleeding, especially associated with those patients who are on ECMO.
Courtney, that kind of lends to your next question.
Thanks, Dr. Rao. Okay, this is going to go to Dr. Shrivastava. What are your thoughts on prophylactic anticoagulation for COVID patients? Does treatment continue through the postpartum period?
Yeah, so great question. And actually, it's probably should have been a corollary to the first response I gave on our regimen. We definitely, in our antepartum patients, put them on anticoagulation, typically, depending on their stability and the relative gestational age, we may tailor our agent to what we use. Most often we use Lovenox for management of our patients. Obviously, if we think there's a chance that delivery may be imminent, either because of respiratory status or gestational age for that matter, we may put them on heparins, so we have the ability to give regional anesthetics if they were to go into labor or need to be delivered. And we do continue them in the postpartum, presuming that we're still working under the COVID window that we're dealing with. We do not send them home on anticoagulation, assuming in most cases that the patients are delivered, and a lot of the reason that they're staying prolonged is for their COVID illness. But once they're able to be discharged, we don't continue them on anticoagulation for that period of time. unless there's obviously an underlying indication for them to be on anticoagulation.
Thank you. Dr. Rao, are there any recommendations regarding nitrous oxide for labor pain management with COVID patients?
Yeah, so we did offer nitrous oxide before the pandemic started. And as it was well underway, we convened with our anesthesia colleagues and our labor and delivery unit leads and decided that because of the way nitrous oxide is used, you have to be very careful with the person who's using it, that they blow directly back into the mask, and it would be considered a high aerosol risk. And so therefore, it was discontinued at the start of the pandemic. And because our rates, especially in Los Angeles, are still on the higher side, although slowly coming down, we still have not restarted the use of nitrous oxide. So our recommendation at UCLA anyway is that we are not currently using nitrous oxide for the risk of exposure.
Wonderful, thank you. Okay, our next question is going to go to Dr. Martin. Courtney, what fetal monitoring would you order for patients hospitalized due to COVID who are pregnant but not experiencing pregnancy complications?
Another really great, thoughtful question that really, I think, directly affects what everyone is trying to do, which is, keep both the mom and baby safe, as well as it does create worry on behalf of the staff and the physicians, right, from the standpoint of how we practice in general as obstetricians and maternal fetal medicine specialists and nurses. So the short answer is that we know that the baby often can show us signs of deterioration far before we see it on the mom. And so in our particular situation, we had an incredible volume of COVID in pregnancy moms admitted to Loma Linda. And we had made the decision that we would do continuous fetal monitoring if they were on high flow nasal cannula or requiring oxygen. And that was because it helped us kind of gauge, not just based on ABG, that lab values or the physical exam or symptom appearance, but also that it did give us an insight at times. When they're off unit, that does create challenges for staffing potentially. I'm amazed to hear that even a hospital nearby us up in the high desert had a drop in volume. We felt the other, and so none of our people ever floated, and it was actually, we had a huge crunch on staffing because our volume was still going in full speed with our regular labor and delivery on top of the COVID antepartum care, and then floating them off to ICU was a challenge, right? To be able to do continuous fetal monitoring and maintain that sort of approach. But I do still believe that that's the right thing, and when women are requiring more and more escalation of care and oxygen, that we definitely want to be monitoring the baby, not just because of it shows us mom, but also because we would potentially intervene depending on the gestational age, or not necessarily with just delivery, right? But changing oxygen delivery system, potentially optimizing the care that they're getting. And then of course, potentially delivery. And I would say that if they were not viable, we did traditional dot tones Q shift. And I don't know if Dr. Shrivastava has any other piece to weigh in there, Dr. Rao, compared to what you all did at your institution. I think it's a really important question because that's really like the day-to-day that we're doing. And I think at our institutions, we had so many that now it's become very routine for us. But I can imagine if you had a very sick mom just come in, you would be asking these questions and wondering what the right answer is. And so that would be kind of what our approach was. Did you guys have any other feedback on that?
That's very similar to what we were doing. With patients on high flow, we definitely had them on at least continuous monitoring. Now, there was a point where they kind of reached a steady state where they weren't worsening at least, and they were able to maintain their oxygen saturations. We had a cutoff of 94% with our pregnant gals. So they were able to maintain them above 94% on whatever settings they were. We would give them time off the monitor. Obviously, if there was change in that oxygen saturation status or et cetera, we put them back on rather immediately. We had an imperative to try to keep these patients on our floor so that we had more direct access. Obviously, if they became more critical, that became more challenging. And then that entertained questions of whether we needed to deliver or not. The logistics of trying to effectuate delivery on a patient who's respiratorily compromised quickly is as we have all experienced, extraordinarily difficult. Just getting to the ICU, donning, getting in there, getting a whole team in there, a NICU team in there is extraordinary, is a logistical nightmare. Even on our floor, it was a nightmare, but let alone if off floor on a different part of the hospital. So, you know, we maximized what we could, the oxygen delivery system capacities within our own institution, within our own suite before we took a patient up to the unit. And that's largely how we managed them.
And we did the same. I think that that makes so much sense. And I wonder though if our experience might just be because we have those resources at you know, a larger hospital. But it did make sense at the time for us too to try and maximize and teach our nurses high flow nasal cannula, understand that. And I would make one other caveat that sometimes people get hung up on the SpO2, but remember if they're I think a clinical pearl would be if the patient is breathing at 30 times a minute still and barely hanging on at 95, that's not an appropriate SpO2. I mean, and really educating the nurses about what they're looking for, right? To give that feedback to the physician teams, because you're treating work of breathing as well. And I did see sometimes that people were comfortable with a pulse ox that was 98, but the patient was breathing 40 times a minute. So we're, you know, really integrating both just the hard number, but how does the patient look, and training our nurses up. I think that's they are our eyes and ears, and never could I've imagined how important learning and building those relationships with your frontline nurses would be. I mean, I already feel like we all think it is, but when you get in a pandemic like this, you really rely on them. And so engaging them and educating them to respiratory failure signs and symptoms is so important.
Yeah, I just want to echo one more thing. What's actually extraordinarily important, what you just said, is that, and this actually goes to when we're training just the residents and our fellows, that yeah, you're right, oxygen saturation is not nearly the entire picture. And actually, I've had to start specifically telling nurses and residents to not just get a gestalt of their breathing, in the sense that you see the standard, you know, they were reading 18, respiratory rate is 18. I actually want them counting them with a stopwatch to see what their actual respiratory rate is, because it's amazing when you actually count what the actual difference in the number is relative to what's being charted. And then yes, the work of breathing has to be evaluated, because if they're using accessory muscles in their neck and in their chest to maintain that respiratory rate or breathe, that, you know, they need changes in their high flow settings, or to be switched to high flow for that matter, specifically increasing the rate and to accommodate that respiratory rate and to bring it back down. So there's a lot of bedside, just basic medicine that kind of gets overlooked with oxygen delivery, and just learning how people breathe and how a pregnant patient breathes. You know, sitting them up more than laying them down, where they have more compression of their breasts on their respiratory panels, especially for women who are more heavy set.
Yeah, absolutely. And we've intervened because we've set them in a bed. No mom is doing that at home. I know I can speak for all the moms that I know and myself, and you get laying in the bed and they can barely get through a sentence. You know, maybe we were maybe not happy with that level. So I think it's hard on that outpatient and maybe a clinical hospital who doesn't do as much of the critical care to really partner with your interdisciplinary professionals to remind them about some of these things in pregnancy that are different, like tachypnea is not normal. A lot of people like to say that about pregnant women, and we know it's not true. So just doing some of that education is so important, both for nurses and your internal medicine and ICU counterparts potentially.
Thank you both for addressing that. My resting respiratory rate's 12. So I think that's something that, yeah, I'm just glad you brought that up. Dr. Cox, I have a few questions for you. We're going to go ahead and get you started here. What's the timing of the newborn bath for COVID positive moms for the newborn?
Sure. So we choose so in general, we delay bathing our baby for at least 24 hours. But for COVID positive mamas, we bathe the babies shortly after birth, as long as their temperature is stable. And we just use an easy soap, like a foamy soap and water bath. We wash down their hair and their body, get all the maternal secretions off, wrap them up, and give them back to mama skin to skin. So we do it right.
Perfect. What are the health risks to the unborn child if the mom contracts COVID? Do the risks depend on how badly the mom is affected by the virus?
This question is so interesting, and I think we're going to be finding the answer coming with all the new research that comes out each month. So based on what we know now, pregnant moms they have an increased risk for severe disease from COVID versus non-pregnant women. However, that doesn't seem to be the case for babies. So there doesn't seem to be severe neonatal complications. Vertical transmission from an infected mom to her fetus or baby has been a point of recent debate and controversy. So there are a lot of recent reports in the literature, and most recently a meta-analysis using almost 40 studies and 1,000 babies that describe possible intrauterine, intrapartum, and then peripartum transmission. And we seem to see it occurring at a rate of about 3% in the third trimester, based on placental pathology and studies and neonatal serology. However, the clinical significance of vertical transmission, which is rare, is really unclear. We just need time. So what we found is that perinatal infection occurs primarily in infants born to women who have an infection within 1 week of delivery. And we know a lot about what happens in the third trimester, but not so much in the first or second. The majority of infants will experience mild disease or just be asymptomatic, but we don't have long-term outcomes on exposed babies yet. And a cause and effect relationship between maternal viral infection and unfavorable neonatal outcome is not proven at all. So currently most research is focusing on moms who have COVID infection in the third trimester, but we have to remember with other infections, like other viral infections, detrimental effects increase as gestational age decreases. So this raises the possibility that COVID may have similar effects when maternal infection occurs early in gestation. So ongoing research and surveillance is to assess the effects of infections in early pregnancy, as well as the long-term outcomes of infants exposed near the time of delivery or after delivery.
Thank you, Dr. Cox. A lot more to come, I suppose, around that. All right, we're going to move on to our final few questions here. The next one will go to Rosa. How are you handling visitors for long-term antepartum patients, including their children?
So for our antepartum patients, we do allow their partner to come in. They're in a room with a big window, so for their children, we do ask that they have somebody bring their children, and they communicate by phone through the window, which is really sad. But just to minimize and mitigate any potential exposure to others, the fathers, they, of course, everybody masks. If the patient was positive, then we don't allow the partner unless he is tested negative. But if they are not positive, then we do allow visitation of the significant other, and then the children can come visit and through the window. So.
Courtney, why don't we go to that question for Dr. Rao?
Okay, sure. Dr. Rao, who is considered a PUI on your OB unit or OB ed? Is it anyone, ED? Is it anyone who does not have a negative test or just patients with symptoms?
Yeah, that's a great question. That's actually evolved for us over time. Initially, we've been universal screening for a long time here at UCLA, and initially, for those who were just awaiting a test back, they were not considered a PUI, and we would just do the full level PPE for deliveries if the results hadn't come back yet. But given that the rates started to go so high in Los Angeles, we switched so that anyone who is either pending a test or does not have a negative test is considered a PUI and would warrant the full level 2 PPE. So that's currently what we're doing right now.
Vineet, I'm going to ask you, we're going to be closing it down here in a sec. I'm going to ask Vineet, we've got a question that's probably not current state, but future state. Once a pregnant woman has had her set, or once J&J comes through, potentially a single vaccine, what do you think we're looking like as far as testing when folks come in labor? Will we continue to test after a full set of vaccine?
That's a great question. Ideally, we wouldn't need to. However, with these variants that are coming out, and until we have documented efficacy against them, I think we have to continue to test, not only for the moms, for the patients, basically to know how to manage them if they are having hypoxic issues, but also because of the infectivity and the rate of risk of transmission to surrounding providers and to our nurses. So, for the time being, I can't see us not, decreasing our testing until, we get to a level where the positivity rate is down, the rate of new daily cases is down, and that the variants are at least managed effectively by the vaccine. I suspect with variants as the way they are, they're going to keep popping up as long as the positivity rate's high. So it's a race right now to get people vaccinated and to see how it affects in the community. So it's a little hard to read right now.
Yes. Thank you so much. You know what? We'd love to go on for a few more minutes, but I think we're going to cut it short. Next slide. Thank you to our clinician presenters, all of you, and our attendees for joining today's webinar. The questions that came in, I'm sorry we didn't get to all of them. I also like to recognize some comments that came in, which were very fruitful and beneficial for everybody, and we appreciate your time, the time you took to put those comments in. Next slide. We want to go ahead and just remind you again, it's a rapidly evolving situation. Please go ahead and consider the recommendations of your local health department, CDC, NIH, and know that these guidelines and recommendations really need to fit your own institution. Next slide. We want to make sure that you're aware of our wonderful California Perinatal Program's website. It's a combination of input from CP and CMQCC, both out of Stanford School of Medicine. And there are important California updates. Next slide. As you can see there on the top. The other thing that's there is all information about these webinars. That's where today's webinar will be located. And I want to specifically point out our last webinar in September that was about the Latinx community. Those slides and the recording are still available, and the slides have been translated into Spanish. So that may be a resource that many of you could utilize, and we hope you do. So please consider that. Next slide. There are some hospital resources. We've also got organizational recommendations from ACOG and SFMM. Listen, thank you everybody for joining us today. We thank everyone out there who are caring for patients, and we wish you all wellness, and we hope you all stay safe. Thank you everybody, we appreciate it.
Thank you.
Thank you.